The common causes of shoulder pain are injury to the shoulder and its shoulder girdle in the main throughout all of life. But each decade of life has a slightly different prevalence of cause of shoulder pain. So that, for instance, in adolescence, a teenager with shoulder pain normally has instability of the shoulder rather than any degenerative problem. As we get older, so in mid to late adult life, we start to get wear and tear of the tissues around the shoulder, that is the rotator cuff, and therefore problems of rubbing or pain generated by the tissues becomes more common. As we get older, into later middle age, then tearing of the tissues can occur, and in addition to rubbing, causes pain in the shoulder. As we get into the 5th and 6th decades, we get arthritis of the shoulder and the shoulder girdle, which causes pain. And as we get through mid to late middle age, our neck becomes stiffer, and the nerves from the neck can be compressed or irritated, giving rise to what we think of as shoulder pain, but it's actually referred from the neck. One of the things we must remember, though, is that if an infant presents with apparent shoulder pain, that is under the age of 1 or walking age, we have to be concerned about non-accidental injury. And if a teenager or young adult presents with persistent shoulder pain, particularly at night, we must think about infection or tumours. And finally, in senescence, people in old people's homes who are frail and elderly or malnourished, we also must think about infection as a cause of shoulder pain. So each decade has its common causes, but overall we must think about infection and injury as common causes of shoulder pain throughout life. The rotator cuff is a remarkable system of muscles and tendons which attach the muscles of the shoulder blade to the shoulder ball or the humeral head and keep the ball and socket together, whatever the position of your arm is in space. It's a coordinated system of muscles and their attachments to the bone, so that the majority of the muscular attachments to the bone are under or supporting the humeral head like a muscular hammock, whilst the tendinous part of the rotator cuff is above the equator, so suspends the humeral head against the socket. And it's by the coordinated action of all these muscles that the ball stays on the socket. An injury of the rotator cuff is usually of the tendon part, so the part that is above the equator of the humeral head. And when that occurs, the musculature above the equator can't pull on the ball quite so easily. And when it rises up, it hits the undersurface of the shoulder blade above, or can do. Now, most people in life will have a small tear or thinning of the rotator cuff. That's the natural history of the rotator cuff over time. But the majority of those people, and that's about 85% of all the people over the age of 70 or 75, won't have a problem of control of the ball because other muscles cope with and compensate and adapt to the problem very well indeed over a period of weeks to months. And so a rotator cuff injury does not necessarily mean that the shoulder inevitably is unsatisfactory or painful or weakened in any way that is a problem for normal day-to-day life. When the rotator cuff is a problem or generates a problem for a patient, it is usually a combination of pain, weakness, stiffness, or abnormal movement of the shoulder. And each of those can be addressed by exercise therapy in the first instance. If pain is due to inflammation within or around the tendon structure, then that can be treated by injection of cortisone or injections around the nerves that supply the shoulder. to reduce the pain so that physiotherapy and other exercise therapy can be undertaken. But when the rotator cuff tears, and it can, we give consideration to repairing it, providing the shoulder is not too stiff. So physiotherapy is applied to improve suppleness in the joint, and then we might consider repairing the tendons. And that can be done in a very great variety of ways, usually involving some form of keyhole or small open surgical approaches, and anchoring the tissue back to the bone of the ball of the shoulder using a variety of anchoring materials, including stitches. So the rotator cuff can be treated by a variety of interventions, the most important of which is physiotherapy, which can be added to with some forms of pain relief, and then we move on to reparative strategies, but all the while thinking about posture and endurance in the shoulder according to the needs of the patient. When the decision is made to operate on a rotator cuff tear, we do so using either keyhole or open surgery. The idea of surgery is to bring the torn edge of the tendon back into close approximation to the bone that it tore away from. And the idea is to put little anchors or darts with stitches attached to them into the bone, which then are led up through the edge of the tendon and tied to bring the tendon edge back in close approximation to the bone. Once that's occurred, nature takes over and starts the healing process with a variety of hormones and other molecules and cells all brought in to the area of healing, before about 3 months after surgery beginning a much more intensive strengthening exercise program, taking us to between 6 and 9 months after the surgery before a patient is aware that the shoulder is no longer consciously inhibited from movement, but actually just doing things naturally.